All right, good afternoon, everyone. Welcome to our On the Pulse series. Today we have the wonderful topic of healthy heart valves at the heart of the matter. And before we get into that exciting content, I want to introduce myself. I am Chris Fortman. I am the CEO of the Minneapolis Heart Institute Foundation, and so glad to have you all with us virtually today. So just a little background to set the stage for why what you're about to hear is possible. The Minneapolis Heart Institute Foundation is an independent nonprofit organization that was founded by physicians solely to move cardiovascular research and education forward. We're just so proud to keep this important work going still after 38 years. And it would not be possible without the partnership with the Minneapolis Heart Institute and the Abbott Northwestern Hospital, which is the flagship hospital of Allina Health. So again, you can see research and education lead to improved clinical practice. Here are just some pictures lifting up the wonderful research that happens. We have 200 studies happening at any one time. Half of those are industry-sponsored clinical trials, and half of those are physician-initiated research projects. These studies touch over 2,000 patients' lives. Really amazing, and it happens across the spectrum of care, from prevention to interventional to heart failure. We touch all areas of cardiovascular research. One of our favorite programs here is really looking at the next generation of healthcare providers. We have just about 200 alumni of our internship program. So if you have any outstanding junior and senior college students in your life that are interested in research and cardiology, send them to our website, have them apply for our internship program. So not only do we look at the next generation of healthcare providers, we offer CME to current providers, and we're dedicated to the research findings being disseminated across the globe. We have over 200 publications in peer-reviewed journals by our physicians and staff. So these are just some fun pictures because this is really at the heart of the matter. You can see our clinician staff working on research, oftentimes doing first in the world and first in human. We look at the faces of our patients, and we're inspired to keep this work going. And as I mentioned, committed to sharing the findings of our research that in the end often change international protocol. So with that said, we are very grateful for all of you. Many of you support this work, and we just want to say thank you, especially during this Thanksgiving season. And for those of you who don't know us as well, please go to our website. So a grateful heart is a healthy heart, and we have a lot of great resources we would love for you to get more knowledgeable about. So now this is the fun stuff. I get to introduce Dr. Paul Sorajja, who, because of gracious donors who understand how important this work is, his title is the Roger L. and Lynn C. Hedrick Family Chair for Valve Science Research at the Valve Science Center at the Minneapolis Heart Institute Foundation. We're so very proud of that. And clinically, Paul is a cardiologist and director for the Center of Valve and Structural Heart Disease at the Minneapolis Heart Institute. And just as important, he is a doting husband. He is the proud father of 2 wonderful daughters, and I think very recently has a new puppy in the house, which is probably taking a lot of his time. And if that isn't enough, he's also a marathon runner. So please help me welcome Dr. Paul Sorajja.
It's very hard to live up to such expectations, and yes, I'm guilty of having a COVID puppy, but I'd like to welcome you all to this next edition of On the Pulse, and thank you, Chris, for that very kind introduction. She introduced me, and I have the pleasure of introducing the next speaker that we're featuring in this series, and that is Dr. Vinnie Bapat. Dr. Bapat joined us here at our Valve Science Center, which we started a number of years ago. It's one of the first research centers in the foundation. We're really proud of this program as being a multidisciplinary approach where we really have done some cutting edge innovative therapies for valvular heart disease. And we've done a lot of the first in human, first in the world experiences, as Chris mentioned. It's been a real pleasure to be in this program and leading that way. As part of that program, we do reach out to our partners and recruit highly sought after individuals. And I am very proud of Dr. Bapat for joining us this past summer. He is originally from India, performed a lot of his training in England as well as in Canada, and was on staff at Guy St. Thomas, where he became a professor, then moved to the United States a few years ago, and then has now joined us here in Minneapolis. He really is a world-renowned individual. He is a key opinion leader for all things valvular heart disease and cardiac surgical related. He has been involved from minimally invasive and transcatheter work from the very beginning of the story. And on top of all this, he's a nice guy. And so we're here to have him speak about valve surgery. And our goal is to really demystify some of the challenges that have been present in this field, and really talk about how this surgery and this field is life-saving and what it does for our patients, and also the innovative things that we do in research. So without further delay, I'd like to welcome Dr. Bapat and his presentation.
So thank you very much, Paul, for a very flattering introduction. I volunteered to Paul that we'll take care of his puppy if he's exhausted. So let's hope he does offer us that opportunity. These are my disclosures. I work very closely with most heart valve companies, and there's a reason for this, which I'm going to share with you later. I've always been interested in heart valve designs, new therapies, and more importantly, how our patients can benefit. And when I say our patients, it's not just where I practice, but probably all over the world. And Dr. Sorajja has been very modest about himself, but I've known him for many years. The reason is we all connect very well when we meet for different meetings, share ideas, and also exchange ideas which benefit all our patients. So we are not far from history. University of Minnesota, where Professor Walton Lilia practiced, that's where I think the modern heart surgery started. There were other pioneers, and one of the biggest pioneers for heart-lung machine was, of course, John Kirkland. And he always maintained, he was very humble, and he always said that surgery will always be second best. And the reason he said that is because if we find something less invasive, something different, it's always going to be better. And then the onus is on us on how we apply it. Then came an uncertain era. And when I say uncertain is because cardiac surgery really flourished in 1960s, 70s, and 80s. And then entered a very important innovation called percutaneous intervention for coronaries, that is stenting as it is known as. And that really changed the dynamics between surgeons and cardiologists. And surgery kind of became unlike brother, I would say, because it is more invasive. But more so, the complexity increased, and way surgery adjusted to it was, again, looking back towards less invasive procedures. In early days, of course, a lot of the procedures were less invasive because people were scared of the heart. And now I think less invasive has become important because it's important to the patient. And in 2002, one of our mentors and very dear friends, actually, Professor Cribier, did the first transcatheter valve implant. And the journey started then, and 17 years later, as you can see, Dr. Leon and Professor Riordan presented important data on low-risk application of TAVR. As you can see, the one who is smiling is a cardiologist, while the one who is slightly serious is a surgeon. But I think what it showed is it took us 17 years to bring it to everyone who is benefited by this. The TAVR really changed our landscape. And more importantly, it changed the way we think of options. And patients also discovered, of course, there are options to a variety of treatments. It's like In early days, I would say I would go and say, get me a coffee. Now I go, people say, what kind of coffee? What kind of milk? Becomes complicated. So this is why options bring challenges. Options bring challenges because patients always prefer less invasive option. And we understand that. Each of us, if we practice separately, for example, me and Dr. Sorajja practice separately without discussion, I'm going to think what I do is better. He's going to think what he does is better. But here we actually have a shared kind of platform where we tend to discuss what is better for the patient. And let's not forget that technology takes years and years of development, a lot of investment. So there is always a bias towards maybe a more profitable technology, which is pushed on us. And this brings a lot of responsibility on our part. And this was the real birth for a heart team. Heart team concept came from here, that let's not work in silos. And this has to be patient-centered. Less invasive surgery, collaboration, imaging, I think has been a really critical piece because all this is possible because we can look into your heart better before doing anything. And then we can plan it better and give you an option A, option B, or option C, and then discuss with you why one thing is better than the other. I'm going to take you back a bit in time because I want to just tell you about my own journey into how I have got here. And I divide it into simply as pre-TAVR, around TAVR, and post-TAVR. And this is a beautiful view. I used to walk every day. This is Westminster Bridge in London. You can see on the right side, actually at the end of the bridge is St. Thomas's Hospital, where I practiced for nearly 18 years. And pre-TAVR, it was very simple. It was it is still one of the most respected centers in valve surgery and heart surgery. Good results, 1,400 to around 1,600 cases, including pediatrics, neonates, focuses on traditional surgery. Traditional surgery is not bad. In fact, majority of the operations are still done like that. Why we do it? They are safe in most hands. They're predictable complications, predictable results, very standardized technique. The only downside to this may be it takes long to recover. So in 2007, being a young attending in the hospital, my focus was to do that exact traditional surgery. Big operation is better operation for my personality. And then TAVR was introduced. And unfortunately, as I thought that time, I was nominated to be in the program. And I was like, why me? I've just started the job. I want to do now 300 cases per day, which are open heart surgery. And slowly but surely, I changed my mind because I suddenly started interacting with 6 other teams, which I have never interacted before. There were nurses, there were different surgeons, there were imaging specialists. Normally, I used to just read a report. There were cardiac anesthetists, and more importantly, cardiologists. And as you know, there's a famous book called Men Are From Mars and Women Are For Venus. I think it will apply to us as well. We are totally different personalities. There was nothing common at all whatsoever in both of us. And I learned a lot from day one that if this has to be successful, I need to mold myself. And this is my dear colleague, actually, Martin Thomas, who is now a vice president in Edwards Life Sciences. He taught me catheter skills painstakingly, if I may say. And I actually made him put his finger on the heart to see how the murmur actually feels like. And we exchange ideas. We have Jane Hancock as well, who taught me imaging. She actually taught me that, Vinnie, unless you understand imaging, you're not going to get better at it. I learned to work in a completely different environment. This is me struggling in a corner with a headlight, with loops, and you can see the amount of instrumentation we have there. And slowly I learned to declutter myself because a lot of this was essentially just my insecurity probably more than anything else. And most important thing, and I give a lot of credit to Dr. Sorajja and his colleagues, is to teach me one important thing in my life. And it was an important milestone in my career. Share your complications and mistakes. In surgical meetings, we don't show anything. This is a case we did. This is a very early TAVR implant. As you can see, transapical. Something has gone wrong. One of the leaflets was not moving. There was a lot of leakage. So we decided we have to implant a second valve, rightly so. And then what happens is interesting. Is we are passing a guide wire through this valve, and it all looks pretty normal. There's nothing wrong with it. And this is my senior colleague doing the case with my guidance, I would say, because I'm slightly more experienced. We are advancing the TAVR device now in position. And he said, Vinny, this is a bit sticky. It's not going forward. I said, you just have to push hard. And he said, okay, if you say so. And what happened was really interesting. And I'm going to show you the next clip. Is as he pushed hard, the valve just embolized. And we realized that the guide wire was actually outside the valve. And then, of course, we managed to salvage this situation in a very innovative way. But what I realized was I was very I was very nervous after the case, while my cardiology colleague said, oh, we have to show this case tomorrow to all these guys. And I said, no, don't do that. But we have shared all these mistakes and we have got better. The other important milestone in my life, at least, was CT scan and its application. I used to use CT scans for aortic dissection, being an aortic surgeon, aortic aneurysms, as we know. But today, if I look at my practice, I use it for everything. I feel very strongly that CT scan, especially the skills or the what we can see today inside your heart and body. And one thing I must say that coming from two big academic centers here, working with Dr. Lesser and Dr. Cavalcante, I spend a lot of time with them every day. We have got probably the best CT imaging today in the country, or maybe even in the world. And this allows me to plan my cases before. If you meet me in the clinic, I will never give you an answer which is complete. I will always say, I'm going to look at your imaging myself and I'll come back to you if there are any red flags. And if there are any red flags, people do find me suddenly talking to them like Dr. Sorajja saying, I need to discuss a patient with you, or Dr. Bay, can I look at the echo with you together? And I think this is important for the best outcome. Let me just walk you through some of the avenues and some of the contributions which I did for because of this TAVR, I would say, break in the TAVR, I mean say. And here we are. So first of all, we were doing TAVR with two approaches, and then I had a patient where we couldn't do both. And then I came up with the idea of doing a transaortic approach. This is a patient who really, from first generation delivery system, extremely challenging system that time to use in a retrograde manner, but we did really well. I was also a bit skeptical about it initially till my number 7 case. This is a lady with right pneumonectomy who was referred for, of course, aortic stenosis. And this was from another center in England called Birmingham. And the professor there contacted me and said, Vinny, I think maybe your new technique will help her. This case, I went there, we did a case. As you can see, the CT really guided me into this case in where to make the small incision, how to insert the delivery system. And needless to say, this patient really not only did well, but was discharged home after 2 days. And that really pushed me into adopting this technology and then, of course, teaching this access all over the world. Then it led to another journey called valve in valve, and I think a lot of you have already heard about it. If I implant a surgical valve in you, a tissue valve, if it goes bad after many years, we can now implant a TAVR device inside it. Relatively very easy procedure. This is the first procedure we did in St. Thomas's many years ago. You can see February 2010, so nearly 10 years ago. But the early results were a bit of hit and miss. So I decided that we need to provide a robust guidance for this. And the first thing I did was I made a catalog of all the heart valves implanted in two decades and provided these pictures which are useful for not just surgeons, but also cardiologists. And this became our first paper in this field. But I realized that giving just images is not good enough. So the second thing we defined at that time was what is known as true ID. And this is the dimension which is not given by the manufacturers because it was irrelevant by that time. But now this is a term which is included in the ISO standards because this is what is the most relevant dimension in terms of valve in valve. So I managed to classify the valves, define all the IDs, and this is something which we all use today, every day. The third thing we defined was how to implant these valves in ideal position, because this is again a very new field. So nothing was known in this field. And again, this ideal position, if you implant a new device, it gives you the best results. So to collate all these ideas and going into now the next field, which was the mitral valve involved, we realized that there are some other unique challenges in this. And one of the main challenges, which early we didn't realize, was obstruction to the forward flow of the blood. And secondly, embolization of these valves. So I'm just going to show you an interesting case. This is a case done in Hamburg, actually, by a very close friend of mine. Very nice case, no problems at all. But after 5 minutes, the valve has embolized completely. And then on the right panel, there's a movie playing again. 3 months later, we find the valve has moved up. And why this was happening, we did a bit of CSI investigation kind of thing in this. And what we realized is that the mitral valves are different than aortic. Mitral valves close at a very high pressure. So if we deploy like this, which is what we called as parallel deployment, it's not good. What we need to do is a flared deployment. And it's like a cork of a wine bottle maybe, and that will not embolize. And this has now adopted again all over when we do these cases. The field continues to expand. Today, we have got not only aortic and mitral valve involved, but we are pushing the boundaries. And this is where our expertise, knowledge, mistakes, and ability to share that knowledge with all over the world. We get referrals from all over the world for advice. We get phone calls. We get charts to look at. And this is what our team, the expertise it brings to you when we look at you as well. So very quickly, if I showed you mitral valve in valve and aortic valve in valve, the next field is mitral valve in ring. And trust me, it is as complex as it can get, although most people think it's very easy. We have around 25 rings which are implanted. They all have different properties, different sizes. And this is why I'm just going to show you one example. This is a case we did recently here. This is a mitral ring. If you had a mitral repair before, and now the mitral repair after many years is not doing very well, we do look at this option now in selected patients. This is how we do it. This is Dr. Sorajja actually implanting it transeptally, a sapien valve in this ring. Some rings can become circular, but some rings can't. And how do we educate all these centers? There are 756 centers in the United States now doing these procedures. Just imagine the number of centers all over the world. And the way we educated is, this is my daughter's idea many years ago, to make an app. I was completely new to that. So I decided to follow, generally the advice given by most of our kids. We have to follow it. We have no choice nowadays. And then I created these apps. And these apps give all the information. The beauty of these apps is that these are completely free. Now, we rely on essentially donations. We rely on fundings which we generate through scientific studies. And we have kept it unbiased, and entire industry which manufacture heart valves support this without any reservation. And this is now downloaded in 130 countries. And of course, as the TAVR field becomes wider, the utility of these apps is just going to be more and more. So when patients come to see us, we do show them the heart valve they're going to have because the information is there. A TAVR procedure, what is there, it's in the animation is there. If you want to show your family or friends, it's of course there. And of course, there's a very high-end guidance in terms of how to do the procedure, tips and tricks. And if there is any problem, then of course, call one of the experts. As I always say, between 9 a.m. and 5, call me. After that, please call Dr. Sorajja. The next challenge, of course, has been mitral annular calcification. And this has always been a difficult surgical problem. So again, the idea that we work together, we can now bring hybrid technologies to the patient. And one of the early steps in it was using transcatheter valves. And this is the case of Lotus valve, which was implanted nearly 4 years ago now in St. Thomas's. And as you know, that Dr. Sorajja is actually national PI for the Tendyne in MAC trial. And this is only possible because we understand collaboratively each other's strengths and weaknesses, and not, I'm saying, in terms of our skills, but our specialty. I understand transcatheter like he understands surgery. And I think that is why we can do these cases and bring a technology which is meant for transcatheter device to open surgical practice. The TAVR devices, of course, have been used in open surgery for a few years now. And one of, I would say, my favorite cases ever is this. This is a 11-year-old pediatric patient in London. As I mentioned, two of my colleagues used to do pediatric practice. He had had 3 operations before, and the third heart valve had unfortunately clotted off. Patient presented in pulmonary edema. He was on ECMO. He wasn't doing very well. So Connell Austin, who was the surgeon, called me, said, can we implant something else? We could do a surgical valve, but it would be too small. So what I did was I took my knowledge of valve in ring into this case. And what we essentially did is we sewed in a ring into the patient's atrium, and we implanted a 23 sapien inside it. And this was not only a relatively short case, but this gave this child actually a much bigger valve than any surgical valve we would have implanted. The next pictures actually highlight that. When the pediatricians saw these images, they said, wow, this is going to last him at least till he gets age up to 18 or 20. And at that point, when he's fully grown adult, we can then do a definitive operation. So again, bringing that idea into our operation theater has been very important to all of us and not just me. Surgical knowledge has led me to other fields. I would say I've become a hybrid surgeon, if that's the right term to use. My closest to my heart is, of course, research and development. I think this is where we can make a larger impact to not just our own patients, but patients all over the world. And hence, we both have been involved, me and Dr. Sorajja, into transcatheter mitral valves. As you know, that we are probably the largest center in terms of the experience, largest experience in Tendyne device. And I've been involved in the Medtronic 12 device since I was in London and then in Columbia University and now. This is just getting better. We are finding, of course, newer solutions to the tricuspid side as well. And Dr. Sorajja leads a tricuspid clip study. This is a heart valve which has been implanted in tricuspid in a 91-year-old, believe it or not. And then 3 months later, she sent us a picture when she was dancing on the floor. So I think this just shows, in an appropriately chosen patient, we can do less invasive treatments which benefit the patients a lot. Now you will say, Dr. Bapat, but you are a surgeon. So you have spoken so much about imaging, transcatheter. What's happening in surgery? Now, I think this is where I'm going to quickly take you through what the strengths and limitations of surgery are, as well as transcatheter valves are. And this is very critical because if you come to us, at least for sure me, what I will tell you is let me explore all these options and let me see what's the best thing for you. I really strongly believe that fixing your heart in the best way aids your recovery and not the length of the scar. Of course, we have to make sure that you can do well after surgery. These are just some examples because I want to share with you. These are examples because technology has limitations. Technology is not 100%. Technology sometimes doesn't work. And newer technology may not be right for you. For example, this is a patient where the valve embolized. And there are 2 other examples, recent ones, a patient which flew from out of state and we did an operation. 1 year ago, she had a valve in valve, but it was not the right thing for her at that time. It wouldn't last long. And the reason I'm sharing this thing with you is we always do plan B. We have patients where we are 100% sure that transcatheter is going to be the best thing. There is a basket where we say open surgery is the best thing. And then there is something in the middle where we say, we need to try this for you because it may work with some certainty. And then if it doesn't, then there is surgery as a backup. And I think the focus has to be long-term benefit. We don't want you to feel better for 1 month or 1 year. We want you to go back to your normal life for long term. And I think that is finally very, very important. And this has been the ethos of Valve Center. And this is probably the main reason I moved here, is not work in isolation. I think this is important. When I speak, I generally speak for the whole team. We work with other stakeholders on a regular basis, whether it's nursing staff, whether it's OR staff. We make effort to teach them and train them in what we do. We engage our anesthetists, heart failure cardiologists as well. And this has really impacted our outcomes in treating and given us the benefit of treating, really sick patients. And finally, the important piece is imaging specialists. Here, we are lucky that we have people who really focus on one aspect of imaging rather than everything. And that gives us, the best in terms of advice as well as planning ability. And surgery has adapted the change. And I'm going to quickly show you some of the changes in my own practice. I used to, as I said, I trained in St. Thomas's, full sternotomy surgery. Today, there are many options. We can do different types of keyhole operations. And I'm just going to walk you through which options are there today. The red line, of course, is not intentional, but the red line is essentially full sternotomy. And that still is a very good approach for some of the patients, because if I have to do an operation quick and fast, especially if the heart is sick, this is the best approach, because what's going to determine your outcome is it's a quick operation. You don't want to end up with a small operation which has been done, a small incision and long operation, which is not going to benefit your heart at all. So we can do different types of keyhole operations. They do, of course, have advantage of quicker recovery. Usually patients go back to their normal life within 4 weeks, if not sooner. And there's a huge psychological impact. CT scan is really important in planning which kind of keyhole I'm going to do. And also today, more importantly, is we can predict what heart valve size we are going to implant as well. And I've been teaching this for many years now, and now this has become, like, I think in major institutions at least, this is adopted very well. At Abbott Northwestern, we definitely have the advantage because most of the patients will have a CT scan and will be discussed, and we will know what valve size we're going to implant. If it's small for you, we can plan to do something called as a root enlargement beforehand. This is called as a hemisternotomy. This is a small cut in the sternum or the breastbone, and you can do the whole operation through that. The advantage of this, of course, is you don't require any special tools. This is another way of doing it called right thoracotomy, where we go between the two ribs. Of course, one of the small disadvantages of this is we have to cannulate the femoral artery and the vein in the groin as well. This is one of my patients in the past in London. This was the strongest man in Britain. If I had opened his sternum, his career would be over. So we struggled. You can see the amount of muscle mass and how deep the aorta is. But he definitely benefited from this second approach. We have gone to hybrid approaches as well, especially in elderly patients, where we can do a keyhole surgical aortic valve if necessary. And then Dr. Sorajja and his team technically can do angioplasty to a single vessel or two vessels sometimes when it's needed. This is just a case example from my past institution where we implemented this protocol very successfully. So I think if you choose the right thing for right patient, you generally get a very good outcome. And one should not apply, I always do everything like that approach, which again can have many downsides. Similarly, minimally invasive mitral, this is a more resource-intensive program because you need to change a lot of things in your surgical practice as well as training your teams. We are going to slowly implement that here again. Again, you can see there's groin cannulation of the vessels, which is really needed. And then there is a videoscopic or video-assisted procedure on the mitral valve. Majority of the centers currently tend to do this in a very focused way to do straightforward mitral valves. If you have a very complex repair, of course, sternotomy gives you time as well as good visualization to achieve that. The keys finally to better outcomes is accountability. I think we can do all this, but we have to be accountable. And as I said, I learned that from my cardiology friends is share your mistakes, learn better, and apply it in your practice. So this was of Image Me, 2007's traditional type A for sure, and one-man team. And now when I look at my younger colleagues and maybe even myself, what I really want to be is a modern surgeon. I want to be innovative. I want to be engaging. I don't want to close my mind to new ideas, and a really team player. This is just a summary of what we do here. You can see that three of us, that's Dr. Sorajja in front, me looking a bit skeptically at him from my loops. And then Chanel, who was assisting me, and Dr. Shukrallah, who was on the other side. We are doing a case for the largest meeting in the world called TCT. This is a patient we treated, which I think she came from 100 miles from here. She had a really complicated heart condition. And we took our experience into the operation or a hybrid operation theater, and we broadcasted this case. And this patient, I must say very proudly, she's really doing very well. So intra-procedural support, giving each confidence to each other, and I think bringing new technology is what we look at as our responsibility here, and not just something which we do for fun. And lastly, but not the least, I think I would summarize as my role has evolved and it will continue to evolve. I work in all these three fields. Of course, the percentage changes every year, sometimes every week, but my interest is there 100% in all these three techniques. And nothing is over. I just want to share the most important component of my life is we do call Minneapolis our home now, and friends and family have made it very special. And it was our first day here. Dr. Sorajja took us on the boat, and I thought all 365 days are going to be like this. And I just realized that I need a thicker winter coat. I'll stop at that. Thank you.
That was fantastic. Can you all hear me okay? It's all right? Okay, fantastic. Thank you so much, Vinnie. And I want to invite Dr. Bobby Steffen up here too. Your doctor, you can stand right there. So Dr. Steffen is one of our surgical colleagues who joined us from Cleveland Clinic. And want to open this up to some Q&A for a discussion about cardiac surgery and where we are in our current practice. And just want to start with, there obviously have been a large number of innovations in this field. And patients, as you say, often will want the least invasive option. We often get a question, why can't I just have a catheter? Why can't I just do things for the catheter? And then there's often a discussion about mini sternotomy versus open sternotomy. There's often the fear or a question about, do I really have to get my chest cracked open? And can you describe what does cracking a chest really mean? And what does that have in terms of what advantages does that have? And what does that mean for a patient when they undergo such procedures? Maybe Bobby could start here.
Sure, happy to. So
Yeah.
it does sound quite morbid and people do get quite scared when they hear about it, but it's typically a clean cut through your breastbone, either partial or all of it. And then when we're finished, we wire it back together. And because it's a rigid bony structure, actually patients don't experience a tremendous amount of pain from this. Belly surgery, where the muscle moves around, it's more dynamic structure. People tend to have a lot of pain when they have abdominal surgery. When we divide your breastbone and put it back together, it's fixed very securely with wires with very little risk of either infection or dehiscence, and patients actually don't have much pain. And people find that hard to believe. So I usually have my PA come in next and say, you could ask him whatever questions you want after I'm gone. And they agree and they take care of them afterwards. And we see that pain is typically not a huge barrier to recovery from cardiac surgery.
I completely agree. I think, in fact, it's surprising. And being in this field for more than 26 years now, it still surprises me that most of our patients who are mainly elderly actually are walking around on day 2 and day 3. And ribs move, but the breastbone, as Dr. Steffen said, doesn't move, luckily. It gets splintered from both sides. So the trick is to put it together properly. And once that is done, you generally don't feel any pain.
Can you talk a little bit about the hemisternotomy versus a full sternotomy? Because sometimes people ask, well, can I have the smallest scar possible? So can you talk about the advantages between that and the full sternotomy? And does it afford any disadvantage or advantage per se when you choose between the two?
Yep. So hemisternotomy is just splitting the top. I wouldn't even say half. It's a partial cut in the breastbone. And the biggest advantage is we are not compromising on the visibility as well as the entire procedure. The procedure is same. Procedure is not different. So when we do that, the rest of the breastbone is intact, and that allows you to go back to, I would say, to your normal recovery process much faster. That's the biggest advantage. When in some patients, interestingly, sometimes the breastbone is relatively short in height. That means the length of the breastbone is not that much. And then making a 6 to 8 centimeter cut is might as well make a 2 more centimeters, and then the operation is much faster. So we balance that in majority of the patients. I would say that most all of my aortic valves I do since 20 years have been through the hemi sternotomy approach. So I personally don't feel any big downsides. However, 1% of patients may have to be converted into full sternotomy. There's nothing 100%. And if I think safety is being compromised because body always throws you a surprise, I'm a surgeon, I don't persevere saying this is the only way to do it. Most important thing is that we fix your heart properly, and then you're going to do well because of that.
Bobby, what can you say about the recovery from such sternotomy? What would a patient expect in terms of how long would they be in ICU, the hospital? I mean, how long would it take for somebody to feel normal again?
Yeah, so for primary valve surgeries, I typically tell people it's often a day in the ICU. Sometimes there's something little that keeps you there an extra day. It's usually 4 or 5 days in the hospital. And then depending on how healthy you come in, it's usually somewhere between a 4 to 8 week recovery to get back to 100%. So your energy level's the same. You're waking up in the morning, you're doing your entire day. That's what I would consider 100%. And it's usually somewhere in the 4 to 8 week, just depending on how strong you are coming in.
But is it fair to say that most of the recovery happens even earlier than that?
Oh yeah, people typically, so they're out of bed into a chair the night of surgery. They're walking the first day, and they go home tired, but pretty much able to take care of everything they need to take care of from the time they leave the hospital.
And Vinnie, how do some of the discussions about recovery have to do between choices of transcatheter versus surgery? Can you give us an overall view of how do you choose? If one could have one type and the other, are there certain things that push you one way or the other for
Right.
surgery versus transcatheter?
I think this is very important because there are a lot of misunderstandings about this. So transcatheter aortic valve, of course, patients are, most of them, 60% I would say are discharged next day, 100% by day 2, unless of course some complication happens, which is becoming rare. And then the recovery time is 7 to maybe 14 days. If you look at surgery, as Dr. Stephens already mentioned, even with keyhole, it will take 4 weeks for you to recover to a good, reasonable level. I think you could have both, but our emphasis is slightly different. Our emphasis is in highlighting or matching which treatment is good for you based on, say, CT scan, for example. So when I see a patient who is suitable for transcatheter, I always tell them that there's a 3 to 5% chance that if we look at the CAT scan, we may come back to you and say transcatheter is not ideal, or we may even come back and say surgery is not ideal for you. So we are slightly flexible around that. Same thing, conversation about life expectancy of the patient. If we think that patient's going to has a great life expectancy, there is a lot of debate, as you know, at present, which therapy should come first. Should we do a keyhole operation with surgical valve today and do a valve-in-valve later, or do a TAVR today and then do TAVR explant followed by a surgical valve at older age? So all these conversations happen hopefully on Thursday meetings. I would say to the patient that if early recovery is your idea, you should go with TAVR, provided you're suitable for it. But if you want, at least today, from what we know, a longer term benefit, and you're not that worried about 2 more weeks of investment of time today, then surgery is better.
I think it's very clear that we could say surgery is the clear standard, and it's been around with a track record that we know that has been present for decades. And so with somebody who is looking at a very long life expectancy, we often tend to discuss surgery as the first choice. Is that a fair statement, Bobby?
Yeah, I think we know most about the surgical valves and how durable they are. And we also have the option of different valves. Tissue valves are the only transcatheter option. And so they do have a life expectancy. And the younger you are, the lower that life expectancy is. So if you're someone that probably has another 15, 20, 25 years, we'd at least consider putting a mechanical valve in. And that's done only through traditional cardiac surgery.
So let's talk about the mechanical valves, even though that's a little bit smaller segment, but tell us about the blood thinner requirements and what can you expect? The new valves like the Onyx valve, can you tell us a little bit about those?
Sure. Yeah. So mechanical valves, I tell people tend to last forever, but there can be complications somewhere around 1 to 2% a year. They require you to be on a blood thinner. Right now, the only blood thinner that we use is Coumadin. And then depending on how or what position the valve is in, if it's a mitral valve or an aortic valve, somewhere between an INR of 2 to 3. We are exploring the ability to use one lower INR goal, so less thin blood on the Onyx valve, and then also non-Coumadin anticoagulants. So those are both things that are out there and are being explored. We don't know totally what the answer is on those yet, but hopefully someday down the road, it's just like taking your beta blocker or your ACE inhibitor. You take your blood thinner and don't need your INR checked, and there's your treatment for your mechanical valve.
So a common patient who needs surgery is one who has bicuspid aortic valve disease. There's a question from the audience specifically about that. Vinnie, do you want to talk about bicuspid aortic valve disease and kind of one of the things you look for in operating for these patients?
Right. So bicuspid valve disease, of course, is less efficient in terms of blood flow. That's why the turbulence is higher. That's why it degenerates faster, and patients present usually earlier. That means age of presentation is 4th decade, 5th decade, maybe 6th decade. We also know that one can do a transcatheter valve in these patients, in select patients, I would say. But with increasing experience, we also know that in some morphologies of bicuspid, we should not do transcatheter as well. One of the biggest advantages of surgery is, as I said, most patients are younger at that point. The surgery is very low risk in those patients. But more importantly, when we cut out the bicuspid valve, we can always implant a much larger surgical valve. In my mind, that is actually the best advantage of this, because as I mentioned in my talk, there's a therapy called valve in a valve, but valve in a valve is viewed as a Russian doll effect. You put in another valve inside it, which is going to be smaller. Now, if we cut it out, put in a big surgical valve to start with, it gives you a good platform for next therapy, which I think will take you through at least 2 decades, if not more, of mechanical or warfarin-free interval. So bicuspid valves, we analyze them. Only if the patient has high risk for surgery, I would look at a bicuspid valve for transcatheter devices today. And again, we need to look into, is it safe as well for you? Because again, there could be some life-threatening complications on table.
I'm wearing a surgical cap because I just came from doing a bicuspid TAVR patient who couldn't have surgery.
Right.
But there are also aorta abnormalities that go with bicuspid disease. Do you want to talk a little bit about aortic involvement as well?
Sure. So one of the other things is what has been found because of 2 effects. One is called Bernoulli effect, because turbulence through the valve, the main portion, the aorta, the ascending aorta becomes large, and it more so becomes large in bicuspid. And this is when it reaches anything between 4.5 to 5.5. And the reason I say 4.5 to 5.5 is our guidelines keep changing every 10 years. I take a cutoff of somewhere between 5, I would say. This is the time when if you replace the aorta, you take away actually a risk of a very life-threatening event which can happen, which is called aortic dissection. And it's a procedure which was done much conservatively before, because if you added ascending replacement in your surgical practice, the mortality was higher, slightly higher. While now with modern practice, and again, Dr. Stephens come from Cleveland Clinic, where a lot of data has come from that, is that if you add ascending aortic replacement, the mortality and the morbidity is same. It just adds 30 minutes to the operation. And it takes away a very important life-threatening complication. So I would say if you had dilated aorta with a bicuspid especially, we have a less threshold, lower threshold of advising surgery or transcatheter.
There have been some patients who've had bicuspid disease treated with whatever method it's been treated, and then found to have aortic enlargement later.
Yes.
Surgeries as well.
Absolutely.
So, Bobby, there are a few questions here about thresholds for intervention. How do you decide when a patient should have something done for their valve? I mean, what are the key things you look for? Do you even do these in patients who are just found incidentally on the street or what have you?
Yeah, so there are two big categories that we group people into. So one, what is the severity of your valve disease, which we typically grade at either mild, moderate to severe. And then the second is, do you have symptoms? Are you short of breath, having lightheadedness, dizziness? Are you passing out? So those are the two things we look at. So typically we operate on severe symptomatic valve disease. So that is the vast majority of who we operate on. There's some data, especially on mitral valve disease, that even if you're asymptomatic, intervening on you for severe valve disease earlier rather than later can not only preserve your heart function, but actually even preserve your survival. So really on a case-by-case basis, we're looking at even replacing and repairing valves for people who have severe valve disease, but are not maybe quite yet symptomatic.
Vinnie, you had talked about the evolution in surgery over time. And I think what we're hearing is that thresholds have changed because surgeries become safer.
Yeah.
Is that a fair statement? Would you like to elaborate that on?
Oh, absolutely. I think surgery has definitely become safer. And let's not forget that the first open heart was done in only 1953. It's not 400 years for sure. But similarly, the safety of transcatheter has actually made a huge impact on what we do. Because as you know, most of the transcatheter treatments, the biggest benefit is safety. The safety margins are so good that today we are challenging ourselves. So we have some studies here, for example, early TAVR, I would say, or unload. These are the newer indications we are looking at. These are the patients we wouldn't have touched before at all. But now we have a more safer and predictable treatment algorithm. So we are looking at, should we actually intervene a bit before rather than waiting for those traditional parameters which we look at? And would this actually impact your long-term survival? I think that is the next question for all of us.
Lots of data suggesting that the earlier we go, the better likelihood, more likelihood we will impact patient's survival. And we're testing those thresholds about going earlier with current studies, including ones we're doing
Absolutely.
here at the foundation.
Means your mitral clip is a great example in heart failure patients. Today, it is accepted now as you wouldn't wait for medical treatment to fail, CRT to fail, and then do mitral clip. You will probably do it somewhere in the middle. Yeah.
John, are there any other questions from the audience that you'd like to ask?
Yeah, absolutely. The first of which would be following open heart surgery where the breastbone is cut, is it common to have pain in the upper back after about a month or so?
Yes, it can happen. It usually happens in people who are more muscular. And the reason is, I explain patients, I don't know if people can see my hands, but they can, that's great. So the ribs, when we take a breath, the ribs move in two ways. One is what I call as bucket handle movement, and the other is a pump handle movement. So the spine remains stable and the breastbone moves up and down. When we do open heart surgery, we open the chest a bit, and there can be a sprain in the ligaments at the back, and that's why patients get pain at the back. It doesn't last long, but that's one of the common mechanisms by which it can be explained.
Excellent, thank you. There's just a couple more questions online. The next of which would be more of a general question for everyone, but how do I make sure that my cardiologist looks at all the best options for me, and what should I specifically say to or ask to make sure that all the options are explored?
That's a good one. So I would say for that, it's really important to see a heart team. We have, as you can see here, a very multidisciplinary approach with not just the cardiologists, but the cardiac surgeons and imaging specialists. There's a whole team of physicians behind that, including heart failure physicians as well. And the options are about visiting with each of those specialties to see which of those options or which of those physicians would have something to say about your care. It's as Dr. Bapat was saying earlier, it's a very holistic approach. Medicine is much more holistic than it's ever been in the past 10 years. And that's the approach to think about when considering the options.
Excellent. Looks like there's just a couple more questions online. This one might be for Dr. Bapat, but can you do a valve and valve with the pulmonary valve?
Yes, you can. And one of our colleagues, Dr. Santiago Garcia, actually leads that program. with great results, I would say. And again, pulmonary valve-in-valve started same time as the rest of the valve-in-valve around 2010, and it's a very mature field now.
Excellent. Well, I think a good question to end on is, what are you guys most excited about just in the area of heart valve research?
I'll start from Dr. The youngest first.
That's a good question. I would say two things. One, technology is getting so good at a very rapid pace that we get to do a lot of novel treatments and treat people that were unable to get treated previously, which is exciting. And I like working in teams. So these conferences and stopping by everyone's office to run imaging by or a case by has been really fun. So doing innovative things with a lot of super talented people is probably what I'm most excited about.
Absolutely. Dr. Bapat, same
I
question.
think I gave my age away, so it's Dr. Sorajja next.
Well, I think Bobby said it really well. It's interesting because as technology has allowed us to become less invasive, it's required a broader team to apply it, right? So in order for us to do things with catheters and little tools, I need the imaging specialist to tell me exactly where to go with that little tool. I can't just open the entire body up for a gross anatomy lesson. So it's very interesting, and the team approach has been wonderful. And I think that the innovations, as they continue to be evolve and become even safer and more effective, I think it has opened up patients who otherwise would go untreated. And I think that that's a very important aspect of what we do.
So actually, what excites me really is what's going to be important in 2 more years. My focus has always been what's not important today. It's also what's important 2 years down the line. And working with younger people, all our research colleagues here are very young and dynamic, come with new ideas. Similarly, working with the industry R&D, and then bringing those ideas to my own colleagues here and hammer them every week probably is what really excites me. And this is where we are. We have the talent here to do that, not just in terms of clinical practice, but also eventually, as you know, Chris showed very nicely, there are a lot of first-in-man cases. That's what I've done here, and that really excites me every day. Is we are going to see more and more of that in this center as we bring newer things which will benefit our own community.
Absolutely. So it looks like we're right at the end of the hour. So thank you guys very much for your time. Is there anything that you'd like to say to the audience before we sign off here?
Stay safe.
Yeah, definitely. Thank you.
Thank you.